I will speak about Korean medicine CPG for knee pain in South Korea. This topic would be similar to previous Dong-woo Nam's presentation. I think it could be helpful to understand the CPG process in South Korea. CPG for knee pain was based on the knee acupuncture CPG in 2010. After that, we tried to revise this knee acupuncture CPG, but we couldn't because there were the methodology limitations and the scope of the guidelines was only for acupuncture. So we had to conduct this new research and we made this CPG. In March, Professor Eun-jung Kim presented the similar topic about its method and result. In addition to that, I would like to tell you what process has done in the last 6 months. As you know, knee pain is a major illness that causes physical disabilities. It has been ranking high in medical cost per patient and number of visits to medical clinics. This slide shows the number of patients and total medical expense of knee arthrosis in South Korea. As you see, both numbers, blue column means number of patients and red line means total medical expense, are on the right, and the knee arthrosis is high ranking in each sections. In this slide, I want to say that knee pain is very common in older people. This table shows the ranking of disease in people with over 65 years age. It is written in Korean, but I translate it. First, cataract. Second, dementia by Alzheimer's. Third, pneumonia. Fourth, cerebral infarction. And fifth, knee joint disease in the red zone. In the treatment for knee pain, I want to say that Korean medicine has a strength in the clinical practice. There are various types of articles that shows the effectiveness of acupuncture on knee pain, such as clinical guidelines and systematic review. In this situation, the purpose of our research was to formulate a suitable Korean medicine CPG about knee pain, especially based on evidence-based methods and opinions from experts. Through the development of the CPG, we hope to help Korean medicine doctors and knee pain patients to make precise decisions. This process will also create varied and standardized Korean medicine treatment and enhance its credibility. And finally, it will contribute to the promotion of national health. To develop the CPG, the following process was implemented. First step was assemble committees, and following steps setting key questions and literature research and analysis, and guide draft, and official consensus, and final confirmation. Before the presentation of this process, I will explain about the boundary of this research. The knee pain is defined as refers to pain and dysfunction symptoms around the knee, resulting from lesions of the knee joint and soft tissues. And in the Western medicine, the most common reason for knee pain was the following: knee osteoarthritis, rheumatoid arthritis, and soft tissue knee injuries. In addition, significant yet rare cases such as fracture and infection, pain reported from other structures, for example hip, were not included in this research. The first step of the CPG development was to assemble committees. There were several committees, including CPG development, expert committee, a review committee, and advisory committee. It was mainly consisted of professors in Korean medicine colleges. The next step was to arrange key questions by using PICO. to confirm whether Korean medicine treatment has the improvement in various aspects. For example, improvement of pain, function, and quality of life. Comparing with the other group, we established research plan according to PICO. This is the PICO of this study. P was the population of the study. We focus on patients aged over 18, and the diseases were knee osteoarthritis, rheumatoid arthritis, and soft tissue knee injuries. I was intervention, manual acupuncture, electroacupuncture, warm needle, fire needle, pharmacopuncture, wax position, cupping, herbal medicine, and acupunctomy were included. C was control group, sham acupuncture and wax position, placebo, usual care, no treatment were included. O was outcome measurement, the assessment about pain, function, and quality of life, such as BAS, WAMEC, SF36, effective rate, and others were included. After the arrangement of key questions and PICO, we conducted literature research by using following database. Domestic and foreign database used in this study were Pubmed, EMBASE, and Cochrane Library, CNKI, OASIS, and NDSL. After that, as you see the right side, we conducted the extraction process, Prisma flowchart. Two or more researchers independently performed the screening process using the title and abstract, and eligibility checking was performed with full text. We excluded literature review, case report, observation study, study of animal experiment, post-operative management, studies on treatment methods that Korean medicine doctors generally could not perform, and studies conducted in children and adolescents. After extraction, we selected the article and we summarized on the basis of PICO. You can see patient characteristics, OA, and I intervention, Vivian acupuncture, and C control versus acupuncture, and O outcome measures, 5-point scale, 9-point scale, WAMEC, and so on. Based on the above data, evidence level and recommendation level were evaluated according to grading of recommendations, assessment, development, and evaluation. Evidence level was divided into 4 types as follows. Evidence level was assessed by the risk of bias, the quality of the literature, the amount of evidence, and the consistency of evidence. Recommendation level was divided into 5 types as follows. Based on the level of evidence and clinical significance of each clinical question, recommendations were made. Official consensus and formal agreement were reached with Delphi method over a panel of 7 experts with the draft. This resulted in a final recommendation. After then, this final recommendation was completed with the approval of related academic society. For example, Korean Acupuncture and Moxibustion Medicine Society, the Society of Korean Medicine Rehabilitation, and Korean Pharmacopuncture Institute. The result of CPG approved in 2017 were as follows. There are 4 categories, as you know, and each section describes the guideline according to several Korean medicine treatments. Among them, we confirmed that pharmacopuncture had moderate evidence and B recommendation level in the knee osteoarthritis. Look into closely. Blue section means the intervention, and red zone means the effect, and green zone means the control group. Venom and pharmacopuncture showed significant analgesia and function improvement than manual acupuncture and dextrose injection in knee osteoarthritis. Both had moderate evidence level suggesting the significant impact, and both also had considerable and recommendable level. In the case of manual acupuncture, the evidence level was moderate and the recommendation grade was B in comparison with sham acupuncture or inactive control or glucosamine. In the case of electroacupuncture, the evidence level was moderate and the recommendation grade was A in comparison with sham acupuncture or inactive control. In the case of herbal medicine, the evidence level was moderate and the recommendation grade was A or B in comparison with placebo or painkillers. In acupuncture, the evidence level was moderate and the recommendation grade was A or B. Comparison with manual acupuncture or physiotherapy. Finally, cupping, it was difficult to specify the evidence level and the recommended level because of the insufficient data. The evidence level was insufficient and the recommendation grade was GPP. That means good practice point. Despite the various consequences, there were limitations of this CPG as follows. First, it had extensive range of target disease, so we intended to focus on only osteoarthritis in the next revision. Second, quantitative and qualitative limitations of the literature. Much of the research has been in Chinese. Also, the quality of the research wasn't high. Lastly, the grade methodology was difficult to reflect the clinical diversity of Korean medical treatment. Due to the various acupuncture technique and medication prescription, there was a high heterogeneity. With these limitations, we had planned to complement the CPG. First, we expanded therapy technique scope, including physiotherapy, tuna, and manual therapy. Second, target was focused on the disease name. Lastly, we created evidence through direct exclusion of randomized clinical trial. For example, we are currently conducting clinical research on Gabe-Tang. We have conducted the complement of speech, and I want to show the current status in the pharmacopuncture. We found 903 studies, and we did a screening process by the title and abstract. And we are conducting the eligibility checking, and we hope to report the result soon. I hope the better speech will be produced, and thank you for the attention. Yeah.